Thank you for the kind introduction. I'm Fuminori Taniguchi from Tottori University. I'm really pleased to have this opportunity to talk this issue today. The title is Optimal Pharmacotherapy, not surgery, for endometriosis based on the clinical practice guidelines of endometriosis in Japan. As Dr. Kaori showed in the 2021, the third edition of the clinical practice guideline for endometriosis in Japan has been published by JOGR, Japan Society of OBGYN. Recently, in the lower part, the English version of this guideline was published. Here is the crucial evidence in terms of the surgical or medical treatment for endometriosis. Approximately 80% of patients got pain relief after surgical treatment. However, 20% of patients are refractory. A recurrence rate of post-operative pain is very high, approximately 30 or 40% after 1 year. Hormonal drugs were effective. However, the recurrence of pain occurred much earlier compared to surgical treatment. Ovarian cystectomy for endometrioma decreased ovarian reserve. Let me show this flowchart for the management of pain. The first question we should ask is if the patient wishes to have children. On the left side, she wishes to bear children currently go infertility algorithm. That is a therapeutic strategy for infertile patient. If the patient desires to bear children in the future, consider symptomatic treatment under hormonal therapy. If the symptom persists under adverse effect of hormonal therapy, has adverse effect, consider conservative surgery. If the symptom or endometriosis recur after surgery, and other offer symptomatic treatment under hormonal therapy. Also, hormonal therapy could be considered to prevent recurrence after surgery. If the patient has no desire to bear children in the future, administer symptomatic treatment under hormone therapy. If the symptoms persist or the hormonal therapy has adverse effect, consider conservative or radical surgery. This list shows the drugs for endometriosis available in Japan. Several OC-REP progestin, such as the dydrogesterone and Dinagest, LNG-IUS, GnRH agonist, oral antagonist, existing agent. And from this slide on, I'm going to present several clinical questions CQs regarding pharmacotherapy. And this CQ is oral contraceptive low-dose estrogen progestin OC-REPs, effective for endometriosis-associated pain. And answered absolutely yes, OC-REPs are effective. The level of evidence are the strengths of the recommendations as follows. Evidence level 1 is with a systematic review or meta-analysis. Strengths of recommendation B, it means recommended. So far, in terms of this question, 2 RCTs have been conducted both in Japan. In the first, OC-REPs significantly reduced BAS score for dysmenorrhea. In the second trial, a flexible regimen for 52 weeks showed a significant improvement in endometriosis-related pelvic pain In addition, the efficacy of this treatment for pain was almost equal to that of treatment with Dienagest. This RCT was conducted in patients with dysmenorrhea to evaluate whether cyclic OCREP treatment or an extended regimen for 84 days might be more effective in the graph A. In upper left graph A, it shows that the extended regimen was associated with a more significant reduction in the severity of pain compared with the cyclic regimen. Also, in the bottom right graph D, the extended regimen showed a greater efficacy for the treatment of dysmenorrhea, particularly in patients with severe dysmenorrhea. Approximately 70% of these patients had endometriosis, suggesting that the extended regimen might be more effective. This CQ and answer showed that Dienagest is effective for reducing endometriosis-associated pain. Evidence level is 1 with systematic review or meta-analysis. Strengths of the recommended. In this study, the change of INVERSE score for lower abdominal pain after Dienagest treatment were minus 22.5 millimeter at 24 weeks after, and minus 28.4 millimeter 52 weeks after, respectively. On the other hand, the change in the bone mineral density from 24 to 52 weeks of long-term Dienagest treatment was only 0.2%. The reduction rate after 52 weeks of Dienagest treatment was only 1.7%. This slide shows the maintenance therapy with Dienagest following GnRH agonist. GnRH agonist was administered for 4 to 6 months. Then Dienagest 1 milligram per day for 12 months was prescribed. It means the group G. Group D was treated with only Dienagest 2 milligram per day for 12 months. These data show that the GnRH agonist followed by long-term Dienagest maintained the relief of pelvic pain. In addition, this regimen reduced the irregular uterine bleeding during the early phase of Dienagest therapy. This CQ and answer show the OCREP GnRH agonist, progestin, and LNG-IUS was equivalent pain, reducing effect. Evidence level is 1, strength recommendation B. Next, CQ and answer is LNG-IUS, Dienagest, and GnRH agonist are all effective for reducing the pelvic pain with deep endometriosis. Evidence level 2, it means with 1 or more RCTs. Strength is recommendation to be recommended. Here are the results of 2 RCTs conducted to evaluate the efficacy of surgery or hormonal therapy for DE. On the left data, the surgical group red line showed early reduction of dyspareunia, but partial recurrence of pain for 12 months, while the analgesic effect, the progestin group blue line, was more gradual. On the right, another trial was conducted to compare among hormonal therapy, surgery, and combined hormonal therapy plus surgery. At 1 year, dysmenorrhea, dyspareunia, and abdominal pain recurred less frequency in the combined treatment group than in hormonal therapy alone or surgical alone group. this yellow arrow. In addition, no difference in the pregnancy rate after medical treatment were observed. Next CQ is conducted to evaluate the efficacy of pre-operative or post-operative medical therapy for pain. In terms of pre-operative treatment, there is insufficient evidence to determine whether medical therapy is effective for improving the efficacy of surgical therapy. Evidence level 2, strength C. C means recommended but no clear evidence. On the other hand, post-operative medical therapy for as long as possible is effective for preventing recurrence of pain. However, short-term medical therapy has not been shown to be effective. Evidence level 1, strength of recommendation, A, strongly recommended. Next CQ is evaluated the efficacy of medical therapy following surgery in preventing the recurrence of endometrioma. One, long-term administration of OC-REP is effective. Evidence level 2, strength of recommendation B. Also, several RCT showed the continuous OC-REPs administration was superior to cyclic administration. Answer 2, LNGIS does not evidently reduce the incidence of recurrence of endometrioma. Evidence level 2, strength of recommendation 3. Answer 3, long-term administration may long-term administration of DNAGEST may reduce the recurrence of endometrioma. Evidence level 4, it is not based on patient data or opinion of expert. And strength of recommendation, the C, recommended, but no clear evidence. Lastly, I'd like to talk about the use of GnRH antagonist. I will show you the practice uses of GnRH antagonist. First, the upper left, for its inhibitory effects on uterine bleeding and pain as a prior treatment. Subsequently, hormonal treatment is followed. Second, the right side, for switching in case of inadequate responses to prior treatment. Third, for infertility patient to improve symptoms prior to infertility treatment, or after egg retrieval, GnRH antagonist is added as pre-treatment. And after surgery, embryo transfer is performed. Fourth, as pre-operative administration or treatment for post-operative recurrence. Thus, in various situations, oral GnRH antagonist can be used. Here is a case of I experienced a case of an infertile patient with severe dysmenorrhea, as Kaori showed as ECVS. The patient was 37 years. Here is her current medical history. 4 years ago, she visited our department with desire to bear a child. Multiple intramuscular myomas were observed, 2 myomas of 5 centimeters and 4 centimeters in diameter, plus a smaller myoma. She complained of very severe dysmenorrhea. And the other test, hysterosalpingography showed the tubal patency, and findings of hysteroscopy were normal. The 3 courses of IUI were done, but she failed to conceive. 1 year ago, OPU was performed prior to surgery, and then a laparoscopic assisted myomectomy. After 3 months of GnRH antagonist treatment was performed. After 6 months, she conceived by hormone replacement therapy and embryo transfer. She delivered a healthy baby. And the last, I want to conclude as follows. The reliable drugs in our hand are OCREPs, progestin, and GNS agonist antagonist. Individual treatment using the different characteristics profiles of drugs would be the most appropriate approach. Thank you. Thank you so much.
Okay, thank you, Professor Taniguchi. This paper open for question and comment. Any question? Oh, yes, please. Mic あります。
Well, thank you very much, Professor Taniguchi's excellent presentation. Now we have several drugs in use, and maybe any of them works well. And it's very difficult to choose which drug for your patient. So when you choose drugs for your patient in a daily practice, what do you factor in? So what is the order of the importance in your mind?
Thank you. Good question. I think it depends on the purpose or the situation of this patient. And so I think the general antagonist is very strong to get the pain relief. So we have to consider the cost of drugs and the desire for the baby or the desire for treating the pain. So it's depend on this situation, I think.
Okay. Any comment from Luke or Neil? Yeah, please. Luke, please.
I think, Neil, you had your finger up before, so you first.
Well, I think firstly, another brilliant presentation, Fuminori. That was masterly. First of all, congratulations on the Japanese clinical practice guidelines. I think that's a fabulous endeavor, and I think Tasuku, you led that, so I think you all deserve a lot of credit for that. I had just a comment, and it relates to some of your randomized trial work in Japan. I believe that the combined oral contraceptive pill, I think, has been overstated in terms of what evidence base we have. I think I'm right in saying that compared to placebo, we only have 2 randomized trials that show its effectiveness. Now, I think we often confuse improvement from baseline with, which happens in a lot of trials for a variety of reasons, with improvement versus placebo effect. And I think the effectiveness of the combined oral contraceptive pill has almost become enshrined in a number of guidelines. There are a lot of patients who believe that their endometriosis was made worse by estrogen. And I just think we need to bear this in mind. In the New Zealand pathway of care, respecting the evidence base, where there are in double figures the numbers of randomized trials looking at progestin treatment alone, I would suggest that progestin should be considered more as a first-line treatment than the combined oral contraceptive pill. In fact, I think I'm right in saying that from your trial, was it 2017, Tasuku, where you looked at the continuous versus flexible regime, and I think one of the key things that came out of that that trial was in terms of the combined oral contraceptive pill, was the usefulness of the flexible regime for avoiding bleeding disorders. But the way that I read that trial, I think the dienogest proved to be much more effective.
Yes.
And I think that if we think about our younger population, certainly we in New Zealand believe that that early use of progestins and more widespread use of progestins versus using estrogen-based pills is likely to prevent a lot of the problems further down the track for women with endometriosis. I mean, still, we don't have the data to prove that, but I think that we've got some circumstantial evidence to suggest that. So, Fuminori, I don't know what you think about that idea.
I totally agree with you. That very nice. Thank you for good, very good suggestion. I think.
Neil, you think a continuous regimen when we use the OC is important, and we may think about the progestin as a first line treatment for endometriosis patient, a younger endometriosis patient.
Yes, I think so.
Yeah, but we need some data, evidence to support.
Well, I agree. In the younger population, we still, in the adolescent population, one presumes it's no different to the older, to the adult population, but there are more considerations there.
Okay, thank you. Look, do you?
Yeah, I had just one comment, and I mentioned the other dark horse, which is, of course, adenomyosis. And it hasn't really been mentioned much in any of the other talks, but I just wonder with the medical therapy, whether the experts there feel that the guidelines apply just as much to adenomyosis as to endometriosis, or are they a different beast and they need to be treated differently?
Okay, thank you. So, どうぞどうぞ. Last question from audience.
Thank you for excellent presentation. So my last question is how to end progesterone, how to end deniest, I mean progestin, because it's very effective and very convenient to continue, but sometimes it's very hard to decide when this drug should be end, 45 or 50. Do you have any landmark to stop that?
When you stop the drug?
Yes.
I know from the good paper from the Tokyo University. So they said serum estradiol that below the 20 picogram per ml, and the FSH is over 80 milliliter is a good. I think the decision making. I think so. But serum FSH 30 or 40 is not good to decide the menopause or not. So I think that they said that estradiol and FSH we have to check and decide the therapy for the menopausal patient, I think.
Thank you very much.
Okay. Okay. Time is come. I would like to express my great thanks to all speakers for your very stimulating and interesting talk about current problems in endometriosis. The presentation and discussion of this seminar should be very important, and we should share the knowledge with doctors all over the world. We recorded today's seminar, and we are going to release the video on our website, both WES and JES. Thank you for World Endometriosis Society for giving us these precious opportunities. Thank you very much, Luke and Neil, for joining us. Your contribution to our society is enormous. And please have some word for closing from Luke and Neil, please.
I'll start off. I'm really pleased to see that probably because of such high quality research that our guidelines are so similar. I often wondered whether we practice medicine and especially endometriosis management different because our cultures are clearly quite different, but it's good to see that science ultimately leads to the same point, and it's very pleasing to see that we all seem to largely agree on this relatively complex topic. And thanks again very much, Tasuku and the organizing committee for the invitation. And I believe that this is the start of a journey that will continue in the future, a collaboration between JES and WES.
Thank you.
Yes, I will echo what Lucas said. So you've heard from the present, now you're hearing from the past. But I think that's right. It's about looking to the future and to solidify these important collaborations, which ultimately will only benefit those who suffer from endometriosis, and you know, that's what we're all here for. So congratulations to the Japanese Society, and thank you, Tasuku, for having the vision to set up this collaboration. I hope it will be the first of many.
Okay, we hope. Thank you very much, and I'm closing this session. Thank you. Bye.